Hey guys, welcome to today's Mentoring Minute. Mike and I today are going to talk about anterior instability. Kind of also lumped into would be like labral tear, since that's a common pathology that occurs with instability. So when we talk about instability, it kind of fits into the research says it's like two groups. You have the younger, less than 40-year-old overhead athletes who really do best with surgery. Right? Research suggests that if they have one dislocation and they can then go 3 months without another dislocation and get back to activities, they have a good opportunity to get back to stuff. But if they have more than one dislocation, then really they are the best surgical candidate. There's a study that looked at a year follow-up in those that had surgery. 15% had a dislocation following surgery, which is still a high number, versus 61% for the non-surgical group. So really we wanted to suggest to them that surgery might be the best option. So for the other half, the 40 and over group, those are the patients that did well without redislocations with conservative therapy. They were able to get back to regular activities, daily lives. Again, they weren't overhead athletes, right? So that would be kind of where we have to differentiate for them. So what we'll talk about today is some of the special tests that have good sensitivity, specificity, positive likelihood numbers, as well as some of the rehab measures we'll go through. So when we talk about instability or dislocation, right, majority of them happen with abduction, external rotation forcefully, or through a weight-bearing component like a fall. Right? When we talk about, well, what structure is actually damaged, yes, you have the labrum. About 22% of anterior dislocations have labral pathology, especially if they're under 40. The over 40-year-old, you start to get more rotator cuff pathology. So it's very important to look at isometrics. So for here, hold, 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 and then arm by side abduction, hold, hold, hold. Looking at isometrics to see is there rotator cuff involvement as well as labral involvement or other ligament involvement. So if we're looking at the primary stabilizer of the anterior shoulder, it would be the anterior inferior glenohumeral ligament at 90 degrees. So that would be here, which is the most commonly injured one with anterior instability. If we look at external rotation at 45 degrees, then now we're talking about the more middle and superior glenohumeral ligaments. So again, most commonly would be up here. For special testing, right, for inferior instability, you have what's called the sulcus sign. So you're holding the patient's elbow, stabilizing at the scapula, and you're pulling the elbow and shoulder inferiorly, trying to get a sulcus sign near the deltoid. Right, positive test would be seeing a sulcus there. Another test we'd look at, go ahead and lie on your back. Another test that's pretty common to look at would be anterior apprehension, and then posterior relocation would be its match. So again, taking the patient passively through external rotation at 90 degrees of abduction, looking for a patient's response to either apprehension or pain, right? That'd be part one. If you then add a relocation, so a posterior glide to the humeral head, and then recheck external rotation for improved range, less apprehension, that would be a positive test. Studies suggest up to a 39 positive likelihood ratio of 39, which is very high, if both of those tests are positive for anterior instability. So the last one would be the hyperabduction test, right? Stabilize the patient's scapula, keep rotation neutral, then passively abduct the patient's shoulder. If you're able to get past 105 degrees without letting the scapula move, that would be a positive test, meaning there's signs of laxity in that glenohumeral joint, signs of instability. Right, so there's lots of labral tests, lots of instability tests, but some of the more common ones that the research supports would be those four. Another one that they support is a loaded shift. And the nice thing about the loaded shift is you can actually measure it grade 0, grade 1, grade 2, grade 3, where it actually dislocates and doesn't come back, would be the testing. For load and shift, right, you're loading the humerus into the glenoid, right, and then you are trying to shift the humerus forward, the humeral head. So load it, and then try to shift it this way. It can also be done with the patient's arm on their side, load and shift that way, trying to push it anterior. But this is the way they measure grade 0, 1, 2, and 3.